Hi, I'm Dr. Tommy Rhee, and this is Stephanie, the head of the rehab center here. Say hi, Stephanie.
Hello.
Okay, a little bit of my background. I started off in Los Angeles, ART certified, UCLA athletic department, track, field, football, pretty much all the athletic sports in UCLA, and that allowed me to really get experience with a lot of sports and their particular injuries with those sports. ART helped me kind of like define that anatomy, how that anatomy does its action. From that point on, you advance to modalities, and modalities of like simple things, the E-stem ultrasound. And then as I moved on from UCLA with the professional world, then you advance with the more modalities with for instance, like the hyperbaric chamber, or maybe a class 4 laser. And then as I advanced more in my office, I opened up to more modalities. So eventually I got to a point where I'm having everything from acute, chronic type of devices to help these athletes out. So you get to a point where you need to push that envelope a little further. Then Bob and the representative Joe came and showed me the PiezoWave. That's a very interesting device. That helped me really push and help me diagnose problems. So that really created an environment where I have not only my palpation skills, but now you have like another device that you get a biofeedback from the patient, and then from that point on, it allows you to rehab better, specifically movement rehab. Today we're going to talk about the knee. You guys, I'm going to treat you guys as if you're into sports. Our mission statement here, we treat everybody like a pro athlete, so we want everybody to move. In order for you to move, you've got to get the pain out. Pain is increased by probably a sprain, strain, inflammation, bursitis, something's irritating it. So our job here is to look at it in kind of phases. So we look at it like the passive, active on the table, then we'll do some little bit of resistance on the table. Then once we get past that point, then we'll have them on the ground and do some movements, closed chain, eventually open chain, then ballistic. At that point, you want to figure out what you have here. So knee. Now I look at the knee, I have the generic stuff of the 4 ligaments, the ACL, PCL, lateral and medial collateral ligaments. Those 4 ligaments right there. So we know about those. ACL, PCL, you got the drawers test, you know how to do that. Lateral and collateral ligaments, you know how to test that, right? You know the valgus vargus, right? But more importantly, you have to find out the differential diagnosis around that. So we're going to go off the anatomy first, and I'll talk a little bit more of what I typically see as far as like injuries here. So we've got the ligaments. On the lateral side, on the lateral collateral ligament, think also that particular thing called the IT band, if you know that, iliotibial band, right? So when I see IT band, or when I differentiate between the IT band and the lateral collateral ligament, it's just palpating, right? You're going to bend the knee, you're going to palpate, you're going to joint space, and you're going to press on that little lateral collateral ligament. If they don't have pain there, start chasing up there to the tension fascia lata and then do that test, right? So to really define further about where you're at in the tissue compromise, you want to go with the PiezoWave. That will tell you exactly what the damaged tissue is, because the way I use PiezoWave, if I can go back a little bit, PiezoWave is utilized in this office as a diagnostic tool, and after that, more of a treatment protocol. More importantly, I look at it like it pushes the inflammation out. So the whole concept, if you guys had a little bit of a history of this thing, it's sound waves. It's blasting, it's very ballistic sound waves blasting through here. So the way I think about it is that if you look at tissue and ligaments, tendons, muscles, you got fibers, right? Parallel fibers. And then you look at that interstitial fluid there. Sometimes because of the inflammatory world, you get that kind of like recess, the capsule, that's something that kind of like elongates that fiber that doesn't allow that normal tissue to lengthen. So not only is it over, under, bursa, recess, but it also could be inside in the interstitial fluid. You have to get that out to get the normal pattern of that tendon or ligament. So I think that in order for me to elongate full range of motion, I've got to have fluidity. I've got to have a normal tissue there. Thus, I've got to get that metabolic waste, inflammation, something out of there to get that normalcy back in there. Because if you have a tendon that has the pattern that has to be pretty much a linear line, right? And then you have a little bit of fluid pushing out, the travel distance is increased. Travel distance increase, something compromised. Attachment either at the muscle tendon or at the tendon bone junction. So that's how I look at it. So my first thing is I need to get the fluid out. So my protocol here in the office is 2 patterns here. So we'll do one pattern and we'll do the other pattern where I use like a class 4 laser. Stephanie here, let's say she has a little bit of lateral pain in the knee, right? So lateral pain in the knee, I'm looking at either the lateral collateral ligament or the IT band where it kind of takes the patella and tracks it lateral, right? And then hence you'll start getting that chondromalaysia patella, right? So IT band, ilial, tibial band, right? Potential fascial glute max, going down here, greater trochanter, slice down here, and then as it comes down, the lateral aspect of the knee, it kind of spreads out. So as you talk to the patient, you say, hey, how you doing? What's going on? And then they'll say, hey, my knee hurts, outside knee. So right away you're thinking, okay, could be 2 things, right? Where it's at, it could be the IT band, lateral collateral, right? Lateral collateral, let's do the old Vargas test here, it's fine, right? And then she says, okay. So then now I'm kind of guessing it's probably the IT band. So we'll palpate, ouch, 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 too diffuse, too broad. All right, let's find out exactly where it's at. It's the PiezoWave. And then how we set this up, I use the linear head because it's a larger broad stroke right now. So it gives me a generic feel of what I'm dealing with and what location, and then I'll specifically go to a pinpoint head. So then you put the gel underneath the actual gel pack, and then you have contact, and then we'll go ahead and trace around that particular area of the lateral knee, and then I'll get a towel here so we won't get too messy here. And again, so I have, there's settings on here. One is like frequencies and one's intensity. What I do is I put the intensity probably about like 6, 7, 8, depending on the tissue. The smaller the tissue, the less intensity. When you look at a big belly, like a quad or a gastroc or maybe like a glute, you can increase intensity. And then once you find that particular place that's compromised and you get that VAS 5 out of 10, hold it there. Just hold it there, and then what you want to do is get the interstitial fluid pushed out. You want to get that stuff out. And as a sound wave blasts through there, it goes through, and then then you'll see that the patient will say, hey, it's going down. So it'll go from a 5 back down to a 0 or 1. Then just follow the fibers and just keep on going. Once you clear that whole belly, that muscle out, now you're at that point where now you can rehab. Now when they do exercises, now they're not having that issue, that pain. As far as the pulses, once you know the area and you know the actual the compromised tissue from the examination, you should be at 2,500. 2,500, you can go through that real quick. I mean, 4 minutes sometimes. That's it. Now, if you have multiple areas, that's a different kind of situation where I say 2,500 per area, per muscle group, I should say, or muscle fiber. You know, rectus femoris, longer muscle, maybe 3,000. But you know the general area where you had the initial, trace back where it's at, see if you find it, keep it there, and then, you know, if you have other locations, then depending on if it's multiple places, I like to stay at maybe 2,500 per muscle. So maybe 500 here. It all depends on the patient telling me it's gone from a 5 to a 1. So it's almost like a skill. You have to really know your anatomy. Once you find your anatomy, that point pain, stay there, feels good, follow that fiber, right? Landmarks, you know, you got the patella, greater trochanter, you got the AIS, you got all this stuff, landmarks, know your anatomy, and then it becomes very easy from that point on. So then you'll hear a tap, tap, tap. That's the acoustic sound waves going down, okay? And as I'm doing a search, a scan, they would say, we just scan around. I'm going over the actual, like the lateral collateral ligament, and I just kind of hover there for a second. What I'm looking for is pain. So I tell the patient, or I instruct the patient, we're looking for pain. If you want to think about 0, no pain, 10's like a broken bone pain, 5's the number we're looking for. So she agrees, and then we go look for it. So we're scanning around here, and boom, we find it, right? So when we find it, I have a general idea that it's right there in that area where the IT band kind of like gets close to the patella, right? So from that point on, I'll take another head, and I have to shut the device down in order for me to change heads. Then we'll use a pinpoint. And this is a good opportunity for you guys to see how to exchange heads. because the linear head is a good broad stroke head to treat a large area. But the issue is that right now we're trying to do a diagnostic usage here. So depending on the depth, because the IT band is very superficial, we're going to go to a depth about 5 millimeters. So you'll take the pinpoint head, you'll gel it up, so you get a good contact. Good. And then circulate it. Make sure you don't see any bubbles inside there. Put the cap on it. Make sure it's not cockeyed. Clean the gel up. And then plug and play, I believe that's what they say. All right. Good, so I'm going back to my frequency of 4, and my intensity, we're gonna start at 5, and we're gonna go and search for that sucker here, since we know it's on the lateral side, so on the broad stroke probe, we found it. Now we're gonna go to pinpoint it, okay? So I palpate with my hand the lateral collateral ligament, sense it right there, and we're gonna go right on that thing. So I hover around there, I go more posterior, anterior, I just surround that lateral collateral ligament. No pain? No pain. So now we're searching, okay? So we're gonna go where the other end of the head's linear line, so it's a line. So we're just going along that line, and we're going close to patella, and let's say we find it right here. So we got it, right? All right, well, she has it right there, right? So now she has a 5 out of 10. Give me your number as far as your pain.
4.
So she's 4, okay, that's still good. So at 4, we're gonna go just a little more intensity. I've got foot pedals, increase my intensity. And now I'm showing a 7 out of 18. So I'm gonna hover here until we get a 5. Tell me where you get a 5. Okay, let's say it's 5 here, okay? All right, so we're gonna say it's 5 right here. So now I just sit here and wait. So as I was telling you, I'm trying to get that tissue that has an interstitial fluid increased by the inflammation or some type of a metabolic waste. I need to push that stuff out. As we hover here and we stay on the spot, she'll start having decreasing of that pain. So it'll go from a 4, 5, 4, 3, 2, 1. We're going to get down to 1. It takes about a minute or 2. And then, let's say it's a 1 now. So then, knowing your anatomy, we're going to go distal to proximal. Okay, we're going to go up until we find something else. If you don't find anything else, go back distally here. Go back, and then you're just knowing your anatomy, just follow along. So everything looks like along that patella, the lateral aspect of patella. So she's getting that secondary problem with IT band, and that's chondromalacia patella on the knee. So classic stuff when you start getting IT band issue. So this is what we do here. So now diagnostically speaking, we found it. We're at the lateral aspect of the patella and a little bit superior anterior of that lateral collateral ligament. And that's how you pinpoint it. IT band, tensor fascia lata, glute med, glute max. Remember, iliotibial tract comes right down. So I would treat this area, and because an IT band does not contract, right? It's just basically a string. So what contracts are the muscles, right? We got that, right? AZ line, right? So you would look at this area and you find out if you're tense, right? So I'm gonna have her flip on her side, facing me. So we're gonna elongate the IT band. Now what you're gonna do is I'm gonna hold back the glute medius or the iliotibial tract, and you can see it's tight. See, I just pull the ilium back to normal, and it's sort of tight. So you have to work on this portion, tensor fascia lata, glute medius. So then we would take the PiezoWave, and we would work this area here. Then, once you get that fluid out of there, thank you very much. You can lay me. Once you get that fluid out of there, and you have the normancy when she has no pain, now you can. I'll do the ART, which is basically the ART move to elongate to free up those fibers. Then after that, then we would go ahead and do rehab, exercise. So IT band, as you know, the difficulty with IT band is that the symptoms show down here, but the cause is up here. So we have to address this as much as we're addressing down here. All right, so patellar tendon, think about the same thing. You first want to find out what grade he's at. If you're at a grade 2+ in a tendon, you want to avoid doing any kind of aggressive stuff with this. This is not your, because if you have like a micro tear, okay, I can see you dealing with it. But when you have an aggressive tear, you know, grade 2+3, you know, almost like a rupture, you're doing more damage than good. So this device, we don't use it right on the pinpoint pain. We're gonna work around the other areas where the inflammation is kind of leaking out, right? So as you guys know, once you start working with patella and the knee, there's a recess back there where the fluid kind of like collects, excuse me. So patella tendon, infrapatellar tendon, you have the actual area you can palpate where the meniscus is at. Well, in that area, you're gonna have fluid accumulate in there. So when she's extending, the fluid pushes back. When you flex, the fluid pushes forward. If you do a lot of movement like that, it's gonna start going somewhere, right? So there's a recess on the superior patella tendon underneath. So the idea is that you have to get the fluid out of there to have normalcy as far as range of motion, and then pain reduced, then you can rehab them. The idea is that you wanna rehab someone with no pain. I mean, that's the best scenario. So you want to think about all the tools that you have to reduce pain and then do the exercise and movement. And then after you're done, you want to lock them down by freezing them, right? So it's basically push the fluid out in between the interstitial fluid. Then once you get that, then you can do passive active range of motion. Then you can load them up. Then you can do things, no pain. Then after they feel nice and warm, on colic pressure, you got all the fluid out. You don't want the fluid to return, so you have to ice them down. Compression, game ready, Normatec, whatever you have, utilize that to stop that fluid coming down. All right, let's go back to the patella tendon. So let's say we have, so this last one was the lateral collateral versus the IT band. All right, let's look at this guy right here. So we have basically, there's a couple of things that could possibly be, right? So you have that suprapatellar tendon, and you have possibly like a plica. You ever heard of those things, right? Or you might have something like a bursa that's kind of inflamed on the suprapatellar bursitis there. So now, because I tested her, muscle tester, you can just quickly do a test on her to see how far she's come along in her little rehab, or how she's, bend your knee please. So just a simple test, you can just go ahead and have her extend her knee up with resistance right there. Painful? Let's say it's just painful, right? So it's pretty painful just on, like, let's say her muscle shows up like grade 2 out of 5, right? So you know that she has probably right on the distal end of that suprapatellar tendon where it attaches to the patella, she has a compromised tissue. All right, so what we do with that is that because it's gonna inflame, you know it's gonna inflame, the knee always inflames when you irritate that area, we're gonna work around that patella tendon, especially the superior portion of it. So again, I know where she's gonna have pain because we're at a grade 2 plus. So again, you wanna avoid that area, but you have to get this other fluid out of there. So again, gel the area up. I'm gonna start again at frequency of 4 out of 8, and intensity we're going to stay at about 9. I think I got 8 right there, okay? So using my right hand, I palpate the patella tendon, and I'm right at where the patella tendon and the patella meets. So I'm sandwiching it, I'm squeezing together. So that is the place I don't want to touch, because that's where she has, right at that section, she has very sharp pain. So we're going to go, so I have a visual and a palpation point where I know I'm a void. So I kind of hold that area out and I make sure I'm not going to hit that. Then I'm on you can turn the device on with your finger or the foot pedal, but I use the finger here, and then we're going to go around. Make sure you're not on that tendon, and we're going to search for anything that's, again, interrupting that interstitial fluid or that lengthening of that tendon or retinaculum, anything that's irritating. So we're just following around and we're looking, and let's say we have something here. She's at a 4 out of 5, we stay here. I am not on that compromised tendon, so I know I'm not doing any more damage to that tendon. Good, and we'll go to the medial side of it and we'll do the same thing. Just remind yourself, you don't want to hit that tendon. So you know grade 2, grade 3, you know what kind of tendon that is. That's pretty much like a partial tear, right? We don't want to mess with that stuff. But along with that, once the tendon turns into a muscle, you want to make sure that they don't have any trigger points, right? So you kind of like scroll up here, gel up a little bit higher, and then we're going to look for other spots here. So I look at it like this. When the body gets injured, it wants to make a natural cast. It doesn't want to do anything. The problem with the patella tendon is it does knee extension. So it wants to lock things down to hold things around. But the problem is the distal end is compromised. So up on the proximal end of it, it's going to do something, contract, do something weird. But you have to have it relaxed, because if you shorten the muscle up, the distal end becomes compromised again. So you have to relax the belly. So again, trace up to the quad, vastus lateralis, medialis, intermedialis, go up there until you get into the anterior, inferior, superior spine, right? Trace it and you'll find some spots. It's real simple. Use the linear head, scope up. I don't want to switch it over right now, but we'll just cruise on up, and then let's say we hit a spot, hold it there. Just hold it there, and the most important thing is you want to ask them, do you feel pain in your knee? No, you feel pain where the head's at, right? Good, so we stay there, and we hang out there for a little bit. 5, 4, 3, 2, 1. Oh, I don't feel anything. Follow that fiber. Know your anatomy real well, and then just follow the fibers, right? So a couple entrapment points that I like to catch are the intermuscular septum. You want to follow that guy, right? So let's go with medial knee pain. Medial knee pain, one of the big things that a lot of people forget about medial knee is they always think of medial collateral ligament. Well, the funny thing is that if you palpate the medial collateral ligament and they say that's not where the pain's at, it's lower, well, people forget there's a pes anserinus, right? 3 muscles, sartorius, gracilis, semitendinosus. That area right there is the same thing as a tendon issue, right? So you've got to think about what grade is it? Grade 1, you can deal with it. Grade 2, 3, possible tear, maybe trauma, soccer player, kick the ball odd, something, right? So you got to find out what grade. Once you grade it and you think it's about a grade 1, definitely can work on this area. With this area, think about the muscle sartorius. Trace along there, right? With the device, linear head, of course, go along the muscle and you'll find that particular spot that is hanging on, trying to contract. Gracilis, semitendinosus, you know, part of the hamstring muscles. Follow that area and eventually get back to the tendon area and work that tendon. The most important thing about the knee is that how we do things here, we want them to move. So prior to them getting treatment or any type of diagnostic tool, we want them to repeat their movement. So let's say she comes in here, she's a CrossFit person. She says, my knee hurts. I said, when does it hurt? Leg lunges. I said, do the leg lunge. So we do the leg lunge. It goes, oh, I see. She deviates a little bit. She's hiding back. She's heel strong, not toe strong. Okay, why is she heel strong? She doesn't want to put a lot of pressure. When you're, just a little capture there, if you're doing a leg lunge and your toe strong, your patella is strong. If your heel strong, meaning you strike with your heel when you do a leg lunge, that means you're avoiding the actual compression of the anterior aspect of your thigh. You're going to posterior stuff on your hamstring and gastrocs. So just a real quick visual if you want to see like biomechanic movements. Anyways, so we go ahead and we do the motion. So she has pain, then we treat. Diagnostically speaking, we treat, we find a place. Then we actually treat, we work that area up, tendon, grade 1, grade 2, 3, we avoid it, we go distally, right, or proximal, sorry. And then we just work the muscle belly. Then after she goes, feels good, we cleared all the area out, there's no more pain along those muscles, then duplicate the exercise. So she'll do another leg lunge. She feels great. Once she gives you that feedback, she feels great, there's a protocol. Okay. So think about your ligaments, think about your tendons. Don't forget the posterior stuff. Go ahead and flip over real quick, please. Let me go over that real quick. So again, anatomy is very important. You know, I harp on anatomy so much because you don't want to be that one guy, that one provider that knows your anatomy, but then your patient knows it more. That's the most embarrassing thing. You're going to lose your credibility so fast. So anyways, hamstrings. So we got 2 on the medial side, 1 on the lateral side, right? So you got the bicep femoris on the lateral side, semi-groups on the medial side, right? So think about when you have posterior knee pain. Now, depending on the history, depending on a lot of things, it's going to dictate basically what's going on. So if they had trauma in the knee and let's say ACL and then they kept on rehabbing and then now they have posterior pain, if you palpate, you feel that little hump back there, a little bump back there, Baker's cyst, guaranteed. Just all you gotta do is just do the dorsiflexion, stretch it out, see if the plantar teres is involved. If the plantar teres doesn't move and it's still there, right away, you know, Baker's cyst. Baker's cyst, you can manage it. You just gotta be very, very diligent with it. I mean, it's one of those frequency. This Baker's cyst is kind of odd. So the way I treat Baker's cyst, again, PiezoWave. You gotta get that area, you gotta get that tissue normalized. And then what I do is on top of that, I traction a little bit more, open the joint space up, push this with the PiezoWave into that joint. All right. Back here, don't forget another knee flexors back here. So you got the hamstring muscles, and then you got the gastrocs, right? That also flexes the knee. Think about that. So when they have medial knee pain right there on the medial aspect of the posterior knee, think about not only the semi-groups, think about the pes anserinus. But if you feel like it's going down, just dorsiflex her foot, and any pain, no. Then have her actually plantar flex and then flex her knee at the same time. Go ahead. So you're going to plantar flex and flex your knee and then resist. She'll have pain. Think gastrocs. Now you have the trail from distal to proximal. Work that muscle, the belly, the muscle, and the tendon, depending on the grade, of course. Our classic frequency is like 2 times a week for 8 weeks, sometimes 6 weeks, depending if it's acute or chronic. And then we'll go into pricing of how I price things out. But I look at this device as a I don't do too much billing with insurance. Let me go into pricing right now. I don't do too much billing. I like devices that gives me the capability of charging cash. So you want to think about how do I capitalize on that? Because you know how you guys are doing reimbursements awful, right? So I look at devices that are a little bit ahead of the power curve with insurance are going to reimburse. So this thing is fantastic because it's definitely different and you give it instantaneous results right away. So when a patient comes in, again, I diagnostically kind of just palpate, do some orthopedic tests, then I do this as far as diagnostic, right? The PiezoWave. Then I treat a little bit. Then we test. And she says, or she'll say, feels great. Wow, it feels great. Now she has the confidence, you know what you're doing. I have the confidence because I just got confirmation that my palpation plus the device dictates exactly what fiber I'm working on and the treatment protocol. Now you just present the pricing. No big deal. It's like, okay, I'll do it. Because, you know, our typical patient comes in here from other chiropractic, other physical therapists, post-op problems. People are scared to do surgeries. They want something else. And that's what I provide. I show them typically how to diagnose a little different than other offices do. Once the patient knows that you have a hold of their injury and you know exactly what they're talking about, it's so much easier to, you know, do the report of finding and tell them what to do as far as protocols. In my world, you know, we're in practice, we're helping people, but we also have to provide some type of like income, right? So the thing that we hate here in this office is insurance world. So the reimbursement is awful, especially this device. We like to have things different. So cash-based practice is fantastic because the odd thing about when you use like something that doesn't give you a feedback, when the patient doesn't have a good response, they're hesitant and goes, I don't know if I want to pay that much money. So because of this protocol, and then when you do the protocol at the examination, and then they get up and they do the same exercise, now they're saying, wow, it feels better. That impacts you and it solidifies you for that closure of that type of package deal. But the idea is you want to package it up. So because I have 2 times a week for 8 weeks, that's 16, we'll package it up and it'll come down to about $65, $75 per treatment and we lump sum it. So where we see our results is you have to indicate that this is the best device for them, and more importantly is that they have reinsurance and you know what you're doing. So because of those things, it just sells itself so simple with that. It expands your practice real quick and it helps you out for all you know, for your physical guys as far as like rehab, exercise. This is really important because you don't want to have someone from a post-op world to do rehab when they have too much pain. You know, most of the pain is inflammation. You sprain an ankle, why does the ankle hurt when you step on it when it's just that anterior talus ligament, right? Well, it's because that calcaneal kind of tibial junction is fluid in there. Get that fluid out. We'll talk about the ankle later. If you get the fluid out, they feel great. Once you solve this issue, then it goes to the hip, low back. It'll start trailing. They go, I want this, I want this. Okay, so the first time you're probably about maybe 15 minutes because you really have to find out what tissue is compromised. Once you know the tissues where it's compromised, it's simple then. Then when they do the follow-up exam, the follow-up treatment, you know what fiber you're working at. It takes us into a different world as far as our business model.